Assalamu alaikum and good morning. My name is Dr. Tuba Khan. Just a little bit about myself. I am a CAMS registrar currently working in the UK. I'm a member to the Royal College of Psychiatry, and I currently work in Birmingham and Solihull Mental Health Foundation Trust and Birmingham Women's and Children's Trust. So today I'm here to give you a brief talk around recognizing deteriorating mental health and suicidality. There are a few reasons why I think this is important, and I'm going to keep this very, very simple for you today, just to understand the basics, because once we understand the basics, it becomes easier to build on top of that. So the most important thing is that there are signs that emerge in someone whose mental health is deteriorating. And when we talk about being able to help people with suicidal ideation or to stop their suicide attempts or to offer them support, there are things that we can pick up on to recognize that this is happening. This is preventable, but it is the sad reality of the world as suicide is number 4 in the leading cause of death for people who are young adults. Suicide is one of the top leading causes of death in the world, top 20 actually. And one person dies by suicide every 40 seconds globally. And this was reported by the WHO in 2023. So I think it's really important to remember that this is a very, very serious issue. It's as important to talk about suicide and mental health as it is to talk about cancer and other leading causes of death. 77% of suicide occur in low and middle income countries, and this is due to stigma and lack of access to care. Our job today, tomorrow, and forever is to increase access to health, to recognize the signs and symptoms, and to ensure that people have the support that we can give them. Okay. So the learning outcomes for today's talk is to recognize early signs of mental health deterioration. This is something that we can all do, and these can be little things or they can be big things. Second is identify indicators of suicidality across age groups, suicidal thoughts, suicide attempts, and low mental health can look different across different age groups and also based off of neurodiversity. Third is to understand when to escalate or refer for a medical review. So psychology and psychiatry, we go hand in hand, and it's very, very important for us as psychiatrists, for example, to understand when we need the help of our psychology colleagues. And I think it's also very important for psychology colleagues to understand when psychiatry input is important. And 4, explore culturally relevant risk management and safety planning. So these are practical things that we can do. So early recognition matters a lot. So suicide is now a major public health concern across South Asia. And the biggest issue that we have is that it's often underreported. So people will give other causes of death rather than suicide. This can be due to stigma around mental health, or it can be due to legal issues as well. Many individuals first share distress with a trusted counselor or a teacher, not a psychiatrist and not a psychologist. So people might tell people in their family, they might go tell their teachers, they might go tell their, someone in their house, even someone who works for them, that they're feeling this way before they tell mental health professionals. And these symptoms can be misinterpreted. Instead of looking at mental health difficulties as mental health difficulties, people will look at them as nazar, or doesn't pray, or they're just stressed. And this can really delay treatment. So psychologists can bridge the gap between distress and clinical help. Your input really matters because you can allow us to then do our jobs better. So when we talk about mental health deterioration, what does this mean? So this can look like gradual decline in emotional stability or functioning. To be able to recognize decline, we need to know what someone's baseline is. That's why it's really important when a patient comes to you that you ask them, before you were stressed, what were you like? Before you were sad, before you were depressed, before you were anxious, before these problems came, what was your functioning like? How was your mood? Can you rate it from 0 to 10, 0 being rock bottom, 10 being excellent? Can you tell me the functions that you were able to do at home? So what that means is, were you able to wake up and shower in the morning, brush your teeth without being prompted, do your daily routines, go to your job? What were you able to do before this happened? This is their baseline. Often things will get seen as losing patience or getting easily angry or not being themselves. So people will label mental health issues as other things. And their families might even tell you that, just bati ho gaya, or they might say, they're just "Gusse wala hai," things like that. But you have to learn to read between the lines. So we have to look at emotional, behavioral, and physical progression of deterioration. It can mean that they're sad and tearful and crying a lot more than they were before. Behavior means that before, when they used to speak to people kindly, now they shout at them. Physical means that before, when they had the energy to go to their job, they don't have that energy anymore. And recognizing that change from that baseline is really, really important. So, some of the core warning signs of deteriorating mental health, some things are quite self explanatory. So, sadness, tearfulness, irritability, apathy, not really enjoying things anymore. They can have difficulty with their sleeping, so they can't sleep, or they're sleeping all day long. Appetite, so they're overeating or they're not eating at all. Bhook nahi lag rahi, I'm not hungry. Food doesn't taste nice anymore. Behavior, so someone who used to go out and speak to family, or when people come to the house, they sit with them. They don't do that anymore. They're isolating themselves. Isolating yourself is actually a very, very important clinical sign that we need to keep an eye out on. And appearance, so neglect hygiene, so someone who's not changing their clothes anymore. They're in the same clothes every day, even when they get, there's dhabbe on their kapre, but they're still wearing the same clothes. Language, so they'll tell you they feel guilty. They'll show you loss of hope. They'll say burden statements, I'm a burden to my friends, I'm a burden to my family. I don't know what the future holds. I don't know what's to come. So these are all warning signs that things are worsening. There's many, many more, but this is kind of a, quick tour of what to expect. So subtle clinical cues within therapy. So you as psychologists are going to be offering people therapy. There's a few things that might give you an idea that something's not right. So someone starts canceling appointments or has last minute emergencies. When they come in, they're not looking at you. They're speaking in a monotone voice. They're not joking around in the same way they used to. They might also go from future talk, right? Like, I will do this, I want to I used to, or what's the point of doing this? Also, sorry, I'm a bit sick, so I hope you can still hear me okay. Students, so what I mean by that is younger people might say things like, no one understands me, my parents don't understand. And then overcompliance or sudden calmness after despair can also be a big clue that something's not going right. So it looks like someone's suddenly getting better, but what's happening is that they're just giving up and saying the right things to please you. Psychosocial and cultural stressors to note. So these are some of the things that we need to be asking our clients or our patients if they're going through. So family pressure, this can be education, marriage, finances, reputation. They can be gender roles and expectations. So what are the rules of being a strong son, and what is the expectation of them being a son within their family? What is the expectation of being a daughter? Do they have to be very sacrificing? There's also domestic conflict. Always, always think about domestic violence, emotional neglect or controlling dynamics as well. Neglect and abuse doesn't always come in the form of physical. Sometimes it can be emotional as well. And it's important to remember that. So a married couple, physically he's not hurting her. Physically he's not doing anything to her. He might not even be shouting at her, but he's ignoring her completely. That in itself can be emotional neglect. So keep an eye out for not just the big things, but the small things as well. There's also migration stress. This is very important for people who have traveled, let's say, from Pakistan to the UK, who are learning to assimilate and adjust. There can be cultural identity conflicts, shame and honor concern, finding yourself within all of this. And there's also a lot of religious guilt and moral self-judgment amplifying the low mood. So who am I expected to be versus who I actually am. I think these are important things to think about. And we all struggle with this, don't we? Our parents and our society want us to be this perfect person, but we know deep down we're not this perfect person. We all do things that we think that we should be ashamed of. But for some people, this shame can be all encompassing. So when should you be worried, right? Like these are normal things that we're talking about. People face stress, like we talked about in the last slide. People face stress, people face expectations, people face moving to different countries, people face cognitive dissonance between what they should be and who they want to be. So when should we become concerned? So sometimes these people will have direct or indirect talk of death or wishing to not exist anymore. These people will tell you, I want to not be here anymore. I wish I could disappear. I wish I could just go far away. Sometimes they'll say, I wish I can just be asleep the entire time. I wish I could just go to sleep and not wake up. This is really worrying. Self neglect is a big one, especially self neglect that threatens physical health. So someone who does not get out of bed, especially an elderly person, and they're getting bed sores, someone who is gaining significant weight because they're overeating so much and not moving around. So it's becoming threatening to physical health. Or abrupt isolation or cutting contact with friends and family. This is someone who had a circle and then suddenly they cut them all out. That is very concerning. Loss of protective factors is a big concern as well. So someone losing their faith, someone losing relationships or losing their children, death in the family. This is when we should be really worried, especially when they don't have other things to fall back on. And also people who have access to means, especially if they tell you that they have access to means. What I mean by that is they say, oh, I have a rooftop. I could just go on the roof and jump. Or, I have so many medications at home and they're hinting that they might do something. This is really concerning. And then sudden peace or generosity after prolonged sadness. Again, this can look like someone's getting better, but actually maybe they've made up their mind that they're going to end everything. And suddenly they seem that they're at peace, but when actually they're not. And they're giving away all their things and their belongings. I want to talk to you about 8 specific presentation of suicidality. So, like I said, it can look different in different age groups. So you've got adolescent and young adults. So we're talking about preteens and teens. They might have irritability, school refusal, online venting. They might be posting things like, I'm done with my life. There's a lot of impulsive self-harm in this age group as well. So cutting their hands or their wrists or their leg. There can be guilt over academic failure or guilt over relationships, first boyfriend, first girlfriend, things didn't work out. And suddenly they feel like their whole life is over. And then feeling of shame and dishonor. This is a really important one because when people are young, their identity is forming. They are told one thing that is correct by society, by their parents. And then there are things that they want to do, whether they're right or wrong. And finding that balance between those two things, right? We call it the halal haram ratio sometimes. Finding the halal haram ratio that works for you, that takes time. But when you're young, you don't understand that. You are told one thing and you want to do another thing. And those two things coming together are very, very difficult things to happen, especially when there's a big mismatch between who you should be and who you actually are. For adults, let's look at age 25 to 50. There's lots of different things. There's financial collapse, there's marital strain, there's caregiver stress. Maybe not as much in Pakistan, but in other places, there's alcohol or sleeping pill misuse. There's massive misuse in Pakistan of benzodiazepines. So people take what they call Lexotanil. People will misuse that a lot because you can buy it over the counter. And then for older adults, it can look like loneliness, chronic illness, widowhood, fantastical religious statements like, oh, my time's come now, disengagement from grandchildren or routine. Now, these things might seem quite broad. You might say, okay, most of our patients are struggling with this or these issues. It doesn't mean that they're suicidal. But when you see these things happening in people, it's important to ask the right questions and to explore with those right questions how much impact it's having. I'll give you an example. For example, you speak to someone about, you're seeing a lady, she's 45 years old. Her husband has unfortunately recently lost his job. She says, I'm sad. I don't really feel like talking to anyone. I don't feel like eating. And then you can probe further. Are you sleeping okay? Do you have people you can talk to about this? Okay, when you feel low, what are you doing to make yourself feel better? How are you coping? Are you turning to any medication to cope? Are you turning to anything else to cope? Okay, if I had a magic wand and I could just make anything better, what can I improve? If they say nothing, nothing can be improved, my life is hopeless or hopeless, that's a big sign that there might be something more within the surface that's happening. So these things are not to say that every person who's going through these issues is suicidal. But when you see these things, an alarm bell should go through your head that I need to explore this further. Now, these things can look different in people with neurodevelopmental and special population. So autistic people may not be able to verbalize their distress. So you might have to dig deeper. They might have more breakdowns. They might lose structure to their routine. They might start screaming and shouting out of nowhere. People with ADHD are really impulsive. That's part of their illness. So they might commit a suicidal act during their emotional outburst. People with intellectual disability. So these are people who might not even be verbal, might cause self-injury or act out, and may mask their despair. They might just stop eating and drinking. They might start, for example, if they were able to use the bathroom, now they're not able to use the bathroom anymore. Now they need diapers. So these can all be signs and symptoms that their mental health is deteriorating. Try to avoid falling victim to cultural barriers. They might say, oh, adat hai iski, or, this is their character. Try to move past the labels and look at the actual reasoning behind the distress. For people who are not able to communicate well verbally, make sure that you use other ways to communicate with them. One strategy that I always use with my patients when they don't speak too much, and I'm quite worried that their mental health is actually really bad, and they're at high risk of ending their life or hurting themselves in a significant way, I ask them to write things down for me and bring it in. That way, it saves them the embarrassment of having to say it to my face, and I don't read it in front of them. I don't read it out to them, but I will read it to make sure that I'm not missing anything. So even if they're not able to speak to me about it, that's fine. And sometimes it might be as simple as having pieces of paper that have different emotions written on them. So sad, angry, happy, anything like that, upset, all these emotions. And then if they're not willing to speak, say, can you just point towards what you feel? And if the patient has such, significant level of learning disability or intellectual disability where they can't even read, then you can have faces, sad face, angry face, happy face, and ask them to point to that. So these are all different ways to communicate with people. Their communication needs should not be a barrier for us. If someone cannot speak, we should be communicating with them in writing. If someone cannot read, we should provide them with pictures. If someone is deaf, we should have an interpreter. But someone else having a disability should not be a reason that they cannot access care. So when do we escalate and when do we refer? If someone expresses an intent or plan to self-harm or to die, one question that I ask my patients as they're leaving, can you keep yourself safe until your next appointment? Because we talk a lot about suicide prevention, and we talk a lot about helping people with suicidal ideation. But how can we do that if we cannot recognize it? And these are ways to recognize it. Do you think that you're going to hurt yourself between now and the next time I see you? And then they might not even understand, in which case we use what we see and what we see in our consultation. So if someone has severe weight loss, someone looks dehydrated, someone looks like they're not taking care of themselves, not showering, if people start to lose insight and develop psychotic symptoms, saying things that aren't real and embedded into reality, if someone says they're not sleeping at all anymore, it's important to get second opinions from people, from GPs or psychiatrists. It's also important to know who you can contact within your system to get advice from, whether that's a supervisor or whether that's a psychiatrist that you can liaise with to say, my patient has said this, this, and this to me. Can I come and, can I recommend that they come to you? Obviously, always ask for consent from the patient if you're going to be speaking to someone else, unless you believe that there is an acute risk of harm to self or others. If you don't think that the risk is acute and you just want a second opinion, then always ask a patient's consent. We should be able to reach out to family members with consent as well, and when it's safe. For example, 17-year-old girl comes to you. She says that she wants to end her life. In that moment, you are within your rights to reach out to a family member or reach out to, further help to be able to help contain this situation. That is our moral duty. There's also religious and community elders, only when supportive and non-judgmental, that we can also turn to if we are in that kind of a community. So it's really important to build a safety plan or, crisis support map and use culturally familiar language. So support circle, safety map. So this can look like discussing with the patient what their early warning signs are. So before things get really bad, what happens? Someone might say, well, I just stopped talking to everyone. So you tell them, okay, this is when you know that you need to seek help when this happens, because these are your early warning signs that things are about to deteriorate. Some people stop eating and drinking, some people stop talking to people, some people stop taking care of themselves. Then, so think of it as like a box, right? So on one paper, you have the early warning signs written. And on the next paper, you write down the things that they enjoy doing or the things that you recommend to them. So you could say 1, pray namaz, 2, listen to music, 3, do deep breathing exercises, 4, go for a walk, 5, call this friend, and here's the friend's phone number. So when they feel very overwhelmed and out of control, they can look at this piece of paper and say, okay, these are the things that make me feel better. There should always be numbers of people in this toolbox as well, of friends, of siblings, of counselors, people that they can reach out to and talk to, or even just their name or their pictures to remember, okay, this is the person I would reach out to. It's also important for them to have professional contact. So this is a number you can call when things feel really bad. If you hurt yourself in any way, this is the number to call an ambulance. And also a list of things that they look forward to in their life. It might be for someone who's 16, it might be going to university. For someone who's 25, it might be getting married. For someone who's, 65, you're going to see your children soon. So I'm just giving you more cultural appropriate examples, but things that they want, things that make them excited and happy, and things that they look forward to. And keep a list of all those things. And this is really important. Keep written copy in phone or notebook. So you can keep a physical box or you can keep all these things on your phone. So what do you do in a session if a patient tells you that they're unwell? So things you can do is stay calm, listen more than speaking. You have to ask them direct questions. Sometimes we get shy and we get worried that if we ask them directly, that it's going to make them want to do something that's not true. Always directly ask the person. I always say, do I need to be worried about you hurting yourself? Do I need to be worried about you ending your life? If they're very overwhelmed and feeling very anxious, then you can do some mindfulness techniques, deep breathing exercises, or you can ask them to hold hold a cold object in their hands, like hold an ice cube. You can ask them to wash their face. You can ask them, can you point to me 3 things that you see? These are distracting, grounding, and mindfulness techniques. And then evaluate, what is their intent? What is their plan? What are the means that they'll use, and what kind of protection do they have? Always make sure that you document everything, that you inform your supervisor, and you follow institutional protocol. And never ever promise secrecy if life is at risk. You should be telling all your patients what we talk about is confidential unless your life or the life of someone else is in danger. Keeping in mind, like we said, psychology and psychiatry, we go hand in hand. Okay, our partnership has the best outcomes. So indications for a medical review, when should you suggest that the patient go see a psychiatrist or a doctor? So if they have severe biological symptoms, so insomnia, appetite loss, agitation, for all of these things, we can do something, right? For insomnia, we can prescribe them, for example, melatonin. For agitation, we can prescribe them PRN like promethazine. If psychotic features or bipolarity emerge, which I talked about this in my last lecture, be very, very quick to refer people if you think that they might have bipolar signs and symptoms or psychotic features, because medication at this point becomes extremely important. If the patient is having poor response to therapy alone, they came to you depressed, they said their mood is 1 out of 10, and you've done 12 weeks of therapy with them and their mood is still 1 out of 10, then maybe think that psychiatry and psychology needs to go hand in hand at this point. And normalize medication use, okay? It's very, very important that you tell people medication is important. You do not become a reason for them to shy away from medication. You actually become the promoting member for medication. Because if they need medication, they should have medication. And short-term crisis medication can stabilize enough for therapy to work. Sometimes people need to be on medication for therapy to be successful. Sometimes fluoxetine or sertraline or citalopram needs to be given for their depression so they have the will to get up in the morning and come to see you and have their therapy. Maybe they need to have their promethazine to be able to acutely control their anxiety so they can leave their house, for example, if they have agoraphobia. Now, one of the most important slides here will be caring for the clinician. This is you. You're the clinician, okay? Managing suicide risk can be very emotionally heavy and taxing. You need to be taking care of yourself. You cannot pour from an empty cup. Between patients, you need to give yourself some time to breathe, have a glass of water, sit down for a bit, reset your mind. You need to be having active supervision. You need to be having active case discussion and active peer support. If you don't have a peer support in place, make your own WhatsApp group where you meet once a week over Teams and discuss one case where you felt heavy. This is called Ballant Group. I heavily, heavily encourage you all to look at the Ballant Group format to be able to discuss feelings with each other. There's also a lot of rescuer guilt. You should not be alone with the responsibility of that person. Responsibility should be shared with your supervisor, with your peers, being able to unload. And use self-care strategies aligned with your culture. It might be anything. It might be praying, it might be journaling, it might be seeing your friends, spending time with your family. Whatever it is that you need to do, you need to practice self-care. Self-care can mean going to bed at a good time. Self-care can mean eating the food that you enjoy. Self-care can mean watching a nice movie. It can mean anything. Anything that recharges you is self-care. And I will reiterate again that you cannot pour from an empty cup. So this is my last slide, summary and reflection. So deterioration often reveals itself before crisis. Suicide is preventable. We need to be keeping an eye out for this. And this is not just with our patients, but with our friends, our family, and within our community as well. It can look different across ages, genders, and neurotypes. And in South Asian contexts, stigma, shame, and silence complicate the help seeking. So what is your role? It is to observe. It is to ask in a direct manner. It is to contain their emotions, and it is to connect with them on a human level. So here's some reflection questions for you. What phrases or behaviors might you reinterpret differently after today? So things that you saw in one way before, and now after this lecture, you see those things have different meanings. How could culture both protect and endanger mental health? So our South Asian Pakistani culture is beautiful. It's very protective. We are a community. We have family support. We help each other raise children. People aren't alone. People aren't isolated like they are in the UK, like in the West. But it's a coin, isn't it? If one side of the coin offers beauty and support and help and familial ties, the other side may offer expectations. So have a think about what this means. And what would your own safety plan look like if you were supporting someone close to you, a friend or a family member? Take a moment to think about someone who you know struggles with mental health difficulties. What would you put in their crisis toolbox? So thank you so much for this. I hope this was helpful today. I really appreciate you listening to me. If there's any feedback or any queries, feel free to email me. It's tkhan.psychiatry. At Yahoo. I wrote dot, but it's tkhan.psychiatry@yahoo.com. So please feel free to email me if you have any feedback or any questions. And thank you so much for your time. Allah Hafiz.
Assalamu alaikum. Assalamu alaikum, each and everyone. First of all, I'm so thankful to the worthy Vice Chancellor of University of Sargodha, the Dean, the Vice Chancellor, Head of the Psychology Department, Professor Dr. Najma Malik, the faculties, the students, and the Sargothians. Of course, it's a great honor for me to talk with you people on this occasion of a very special Mental Health Day, right from Birmingham. So let's start with the topic. What exactly we want to share with you people is postpartum depression, the new thoughts, new surprises, and innovation in psychology. That's such a wonderful topic. When we talk about new thoughts, we talk about new surprises and innovations in psychology, right? Let's exploring how the mind, brain, and family changes after childbirth. These are the three words: the mind, the brain, and the family. And before we talk about the psychology, before we talk about the theories, before we talk about so many things, it's our duty to must know the three pillars of human psychology, and that are the mind, the brain, the mind, and the family. These are the integrated triangle. The base of this triangle is the brain. The base of triangle is the brain. The hypotenuse of this triangle is the mind, and perpendicular of this is the family. So if unless this is a beautiful and deep question, and one that combines biology, psychology, and relationship, why don't we just go and talk about in a very compassionate and structured way, how does brain, mind, and family changes after childbirth? Because unless I just move on to my presentation, it was very easy. I just can go very quickly to the slides and all that. But let's see that how does brain, mind, and family changes after childbirth? The brain, we call it as a biological transformation. After childbirth, a parent's brain, especially the mother's, goes through one of the most profound rewiring event in adult's life. For example, if we just classify it, for example, if we justify, if for example we talk philosophically, logically, scientifically, number one, what does it mean? There's a change into the hormonal shift in the brain. The first shift comes to the hormone, like oxytocin, which also called the love hormone, surges strengthening emotional bonding and caregiving instinct. This is the hormone oxytocin. Another one is a prolactin, supports, and that is called nurturing behavior. When we talk about the breastfeeding, this hormone plays one of the very pivotal and a very highest role. Now then, cortisol increases to enhance alertness for the baby's need. Then estrogen and the progesterone drops sharply, which can affect mood and energy level. Number two, what happens exactly? I want to emphasize on these three words very, attentively, carefully, because that is the ruler of the whole psychology subject. Structural brain changes. Research shows that areas related to the empathy, motivation, and emotion regulation, like the amygdala and the prefrontal cortex, grow densely. The reward system becomes more sensitive to the baby's cues. Like, for example, if we talk about the breastfeeding and we talk about the newly born baby, the crying, the smell, and the touch, these are the, basic we see that goes on. Memory and the focus may temporarily feel disrupted, often called mom's brain, due to the hormone and sleep changes. Neuroplasticity, the brain becomes more plastic, adaptable, creating new connections to meet the demands. Pretending this rewiring depends upon the attachment and the emotional awareness. What exactly we want to know, we want to apply. Because of this reason, if we will not take psychological impacts exactly in the rare form that should be, it will not work. The mind, emotional and psychological shift. The mind, how we think, feel, and perceives, also transforming deeply. Identification expansion. A new parents must integrate a new sense of self. This can be bring pride, joy, but also con, also confusion. Also, it creates confusion that who am I now? And emotional sensitivity, postpartum emotions can swing widely. High, high heightened empathy and protectiveness, vulnerability to anxiety or depression, especially postpartum depression, and then sense of purpose. The family relationship, the social transformation, the partner relationship, the extended family dynamic, and the home and social life, they all impact upon the system. Then integration from change to growth, deeper empathy and resilience, stronger family bonds, and personal growth. So, what I believe that if we just know that childbirth is not a physical event, exactly what we say is that childbirth is not just a physical event, it is a complete transformation of the brain, mind, and family system. The period following birth refaces how a person thinks, how a person feels, and how a person connects. Understanding these changes help parents adjust with compassion and strength. The brain is a biological, emotional rewiring. I just give you one very simple things which already you know, but when you are keeping in mind, when you are dealing with the patient, when you are talking for the counseling session or any therapy and all, you should know that you are bound to deal three words: the mind, the brain, the mind, and the family. And does you are ignoring any one of these? Does you are ignoring any one of the factor? If answer is yes, then definitely you will be not in a position to provide what exactly you want to tell to your patient and what you want to do with your patient, and hence that things will not lead you in a proper dynamics. So let's see, looking at new research, new therapy. So, for example, as already we discussed that exploring how the mind, brain, and family changes after childbirth, looking at new research, the new therapy approaches, and the world, emotional world of mothers, understanding how psychology can make a real difference. You should know, but when it's possible, when you know the three things in your daily life, that what is the family system in the culture, in the society, in the different areas, in different religions, what is the family's role and what is the family's attitude, behavior, thinking, and everything. And how does, if you don't know the brain structure, you should know what is exactly the brain is. You should know the foramen, what are the different foramen magnum, foramen ovale, foramen rotundum, jugular, lesser foramina. You should know the cranial nerves, olfactory, oculomotor, glossopharyngeal, hypoglossal, facial, abduction, accessory, and all. At least you should know about the mood, about the thinking, about the fear, about the happiness, about the guilt, about so many emotion that comes into the philosophical life of a human. So unless you are not knowing the three things, the brain, the mind, and family, their innovation, their integration, and their connection and reality, how does they combinedly work in a system properly, regularly with one another, you will never be in a position to know a detail about it. Understanding how psychology can make a real difference. After birth, well, for example, if you just what I believe that after birth, many women expect happiness but face unexpected sadness, guilt, or fear. Postpartum depression, PPD, affects about 1 in 8 mothers worldwide. It's a huge number. For example, 1 in 8, it comes about 12.8%. It's a huge burden of the problem. It is a huge burden of the so-called the culturally factored thoughts and all that. It touches not only the mother but also her baby, her partner, and her whole family. Because of this reason, there's a change in the paradigm. There's a change in the classical change, philosophical change, the logical change. And when all these changes comes together, so they are not causing the postpartum depression only with that lady, but it causes the whole system. And system is a family, system is a partners, system is the relative, system is the all the indicators and pathways which are coordinated with each another. Psychology it touches not only the mothers but also her baby, partners, and family. Psychology now plays a growing role in healing these wounds. Now, what I want to tell you that the postpartum depression, sorry, yes, the body and the brains through a reset. There is a self-explanatory word, set and then reset. The thing is that after setting a thing, if there is some confusion, disturbance, something changes, then, for example, at your home, your house is set to welcome the guest, right? Then when the guest comes, there's a lot of here and there changes takes place in chairs, in cushions, in glasses, in everything. They change the situation as it was set before. Then after when the your guests are not there, then the things again reshaped, and you that's why the body and brain goes through a series of rechanging because the baby is in this world, the baby is here, the new generation is there, the new connections are there, the new relations are there, the new thoughts are there, the new philosophies are there, the new responsibilities are there, new accountabilities are there, and each and everything needs a very combined paradigm shift to the resetting of the your mind values, your family values, and the brain values. So brain goes to the huge resetting. You must remember then the hormone rise and fall rapidly. The mother soul identify relationship shift overnight. Just before, one day before of delivery, she was simply an individual. Now she's not an individual. She's a mother. Mother is a huge name. Mother is the name of love. Mother is the name of sincerity. Mother is the name of loyalty. Mother is the name of a personality who take burden of each and every responsibility, accountability, and each and every philosophy of the life. And that's the name is called mother. Psychology called this time a major life transition. The transition is emotional, spiritual, and physical all at once. This is a transitional period. Because of this season, after the delivery, all of a sudden she is having a paradigm shift in responsibilities, in emotional values, in responsibilities, in thoughts, in needs, in demands, in values, each and everything, but it is a transitional period. She needs some time. A mother needs some time to talk about it. A mother needs some time to decide. A mother needs some time to realize. A mother needs some time to coordinate. And hence, when mother needs all that, this is a transitional period and it is embedded in three factors: the emotional, the spiritual and physical all at once. All three comes all of a sudden. The moment before she not delivered and the moment after the delivery of the baby. A depressive illness that can happen within a week or month after giving birth. That is the very, very common. In my practice, as a lot of mothers talk, they just talk about the postpartum depression, a depressive illness that can happen within week, months after giving birth, last longer than baby blues and affects daily life. Common symptoms: sadness, anxiety, loss of energy, guilt of fear being a bad mother, trouble sleeping or connecting with the baby, hopeless thoughts or panic. It's treatable and reversible with support and therapy. There is two things. One day I asked one con- in a counseling session, I asked one thing. Can you just tell me what exactly counseling means? Many said to give advice. I said no. Many give to give suggestion. I said no. Many give to give a clear guideline. I said no. They said so many words. But what exactly the counseling means? That you just place the facts in front of a person, whether a mother, whether a father, whether a family, whether a patient, whatever. Just place the facts. Let's he or she decide what's good for them, for their baby, and for their situation. In their own situation, what they feel is good. So the therapies, the counseling, the support will definitely will work if your heart is beating on the drums of humanity, अगर आपका दिल इंसानियत की लय पे धड़कता है, अगर आप इंसानियत की पल्स को महसूस कर सकते हैं, अगर आप इंसानियत के नक्शे व फराज जानते हैं, so what I love to say, if your heart is beating, a psychologist must be having this quality. Heart must be beating on the drums of humanity and to feel it close to your heartbeat. It's very necessary, it's very essential कि आपको माशरे के ज़ेरो बम नशे व फराज तारीख की रोशनी नूर और जुल्मत और आपको उसके तमाम इदराक फहम एहसास शऊर लाशऊर तो शऊर उन तमाम के जो नगमे हैं अपने दिल की धड़कन के करीब रखकर समोकर समझकर एहसास करके अगर आप चलेंगे definitely be a good psychologist, definitely you will be a very sensitive woman. And what I can say that really you will fulfill all the dreams for the patient, dream for the humanity, dreams for the subject, dream for the psychology, and that will become a beacon of light for those who are groping in dark. If your heart is beating on the drums of humanity, what I must say. Then the traditional view, earlier explanation focused mainly on hormones, physical exertion, While two, we know what that's only one piece of the story. Neuropsychology and brain science reveals deeper emotional and social layer. The mind changes to not just the body. So here the trend has been changed completely. Trend is not like that as it was before. The philosophy is not that which it was before. It changes entirely. The philosophy, the logic, the thoughts, they just thought so many things. So new psychology and brain science reveals deeper emotional and social layer. The problem is we just talk about the social problem. This is the concept where I completely focus my all energies that if as a doctor working in the obstetrics and gynae department and working with the women's health, if a patient is with me having so many diseases and the cause are the social problems, the social problem layers, the social problem complexity. And you peoples are the champion of the social problem. You peoples are the champions of the A to Z of the causes to philosophy of the social problem, which I don't know. But the problem is there's no bridge in between me and you. You are the champions of the social problem. I'm the champion of the diseases and the medicine. And that is what's required. The treatment of so many things require deeper emotional and social repair. The mind changes to not just the body. We deal with the clinician. We deal the body. We deal the body. The 95% we deal the body's problem, the sign and symptom, the clinical, the history, the present complaints, the past complaints, and this and that. But all we justify about the body, we talk, yeah, your heart is working good. Okay, you are fertile, your uterus is quite good. You are good in your kidney, in your heart, in your lungs, in your stomach, in your brain, in your this and that and all. We randomize each and everything, each and every philosophy, each and every thought, each and everything, just considering the body and mind, and to treat the symptoms and to treat the cause of the disease. But we never know the social problems, we never know the change of the mind. And that is the difference in the subject, that is the difference in problem, and that is the difference in between me and you and you and me. So what I wish that we should be the master to know the social layer, what is the social technique, technology, philosophy, and logic of the social problem, and you should tell us about other things around. New, what are the new? Research says MRI scans how that a mother's brain actually reshapes itself after birth. Maternal brain plasticity, area linked to empathy, memory, and emotional regulations becomes more active. In depression, some of these circuits goes quiet, especially in the prefrontal cortex. Scientists are studying these patterns to predict who might be at risk and how therapy can balance the brain. Because of this reason, it is completely what we believe is these philosophies are not integrated to one another. What exactly the new thoughts, what exactly the new sciences are to fill the gaps Why don't we had such a huge topic of the psychology? Why not to update it the more structured form, more structured form? They should know the what is the maternal brain plasticity, how does MRI work, how does the areas, the different levels should know the sympathetic, parasympathetic nervous system. We should know the cranial nerve. We should know the foramen. We should know the branches. We should know their division, and we should know so many things which we don't know. And we believe And what I believe personally, the psychology should be reshaped, should be rebuilt, should be reviewed, and to bring more clinical. And by more clinical means they should involve into the hospitals, they should involve themselves into the obstetrics and gynae department. Such a huge number of influx could be possible if you just revisit your curriculum. And what I personally believe, the psychology people must be given a chance to go to the patient, to talk, not only to talk to the patient, but at least to deal with the baseline medication, at least to go with the first line of treatment as the doctor they do into the hospital. And it will be only possible when we will just revisit our curriculum, we will just revisit our thoughts, when only we will revisit what we should do exactly in our philosophy, in our thought, in our curriculum, in each and everything. Unless we will not decide properly to complete the bridges, और अगर हम उन bridges को complete नहीं करेंगे, उन gaps को हम नहीं पूरा करेंगे, तो we will never be in a position कि हम psychology को एक नया shape दे सकें. What my personal wish is, what I feel that during my visit to so many universities of Pakistan, and when I went to visit the psychology department, आपके बच्चों में उतना ही जज्बा है, आपके बच्चों में उतनी ही हिम्मत है, आपके बच्चों में इतनी अज़्म है, आपके बच्चों में उतनी ताकत है, आपके बच्चों में उतनी ही सोच है, आपके बच्चों में उतनी ही फिक्र है, आपके बच्चों में वो सब कुछ मौजूद है जो एक मेडिकल कॉलेज के बच्चे में होती है. Why don't we update our curriculum? Why don't we should not revisit our curriculum? Vice versa, as I said earlier, also, yes, we should do one thing and we should revisit our curriculum. और हम अपने हॉस्पिटल्स के दरवाजे, चाहे वो गायनी हो, ऑब्स्टेटिक्स हो, कुछ भी हो, साइकोलॉजी हो, साइकेट्री हो, ऑन्कोलॉजी हो, हम अपने दरवाजे खोलें और हम उसमें सीखें आप लोगों से सोशल प्रॉब्लम, सोशल लेयर्स, सोशल कॉम्प्लिकेशन, सोशल वरीज, सोशल माइंड स्ट्रेसेस हम आपसे सीखें और वाइस वर्सा आप उसमें हमसे सीखें. एंड दैट विल बी एरियाज आपको पता होना चाहिए कि दैट व्हाट एक्जैक्टली शुड डू. Then a psychological view. After giving birth, women often ask, who am I now? Right? Their identity changes and the new one take time. Many mothers feel torn between love, fear, duty, and fatigue. Psychology sees that's a normal but powerful emotional transformation. When stress or trauma interrupts the process, depression can develop. The problem is we just talk about the final product and that's a depression. But in between the brain, in between the mind, in between the family, in between the trauma, in the fluctuation causes the disease, problems, complication due to the trauma. So many things are there, but we never discuss about modern psychological approaches. Yes, you know, that is CBT, cognitive behavioral therapy, helps mother challenges guilt and negative thoughts. Interpersonal therapy, IPT, focuses on relationship and all terms. Then compassion focused therapy, CFT, reduces shame and self-criticism. Mindful based therapy teaches and present and calmness and present moment awareness. Each approach works to rebuild confidence, balance, and connections. So, what my aim to say is that if we are using the therapies, we are using all, you people are exactly, many times I feel you are having same knowledge as we as a clinical doctors in the hospital we do. But the only difference is if you just be top up with as into the world is going on. My problem is the problem is कि हम world में जो top up education in psychology है, that is correlated with the psychiatric department. As my daughter, she's working to the Royal College and practicing in United Kingdom. That is, she said, Daddy, that there's nothing hardly different if they just to be updated. So my philosophy is if just updated with some more things, more therapies with more meaningful than it will be. Then attachment bonding, heart of this story. The emotional bond, it is a force of attraction between two bodies is called bond. So what does it mean? The emotional bond between mother and baby is built through eye contact, touch, and calm. For example, in human philosophy, आप देखते हैं आंखों ने देखा फादर, ब्रेन को मैसेज गया फादर, फीलिंग्स बेटी की आई, राइट, सा टच एंड यू फील सुकून आपको महसूस हुआ कि योर फादर इज देयर, राइट, वाइस वर्सा, माँ ने देखा contact, eye contact hua, touch hua, and she got the motherly feeling. So contact, touch, they creates a huge change into the body. The difference is when we study into the medical college, we study in a different way, and you people study in a different way. What I believe that same thing, same topic, same philosophy, same complication, same people, same society, वो आपके पास आते हैं, आपसे चाहते हैं, आप काउंसलिंग करते हैं, आप उनको डील करते हैं, आप हमसे बेहतर उनको जानते हैं, तो why not we should learn together and we should go together and we should move together, and that is my aim. Inshallah Ta'ala, what I'm trying. In our societies, people rarely talk openly about sadness. Families says be strong or other had harder. Yet behind the silence, many women struggle alone. Modern psychology encourages compassionate conversation. So there's one thing. There's one thing I want to say and I want to share with you, and that is a very very important thing, and that is the families in my daily practice. मैं बहुत सारी औरतों को देखता हूँ, दे आर जस्ट सफरिंग इन सम सॉर्ट ऑफ डिप्रेशन, ऑल दैट, लेकिन मैं खुद ही डील करना उसको चाहता हूँ, या डील भी नहीं करता, कहता हूँ फिक्र नहीं करो, थोड़े अरसे की बात है, तुम खुद, आई टेक इट सो लाइटली. The problem is that the mothers, they go to the clinical doctors. They are the basically gynecologists. They are not the psychiatrists. They are not the psychologists. They are not. And the problem is that they just take it so easy and they take it so light. But what modern psychology in the world encourages compassionate conversation with families. क्या हम करते हैं with the doctors in obstetrics in gynae? नहीं. That's a deeply meaningful addition. We talk about compassionate conversation. It's a very deeply word, and it is a deeply word, and that it is an addition, a very relevant in the context of postpartum and prenatal well-being. And then after childbirth, emotion can run high, love exhausted, confusion. It happens. Compassionate conversation should be, they are dialogues noted in empathy, kindness, presence, shared humanity, and then what they matter after. Parents are emotionally sensitive. Misunderstandings can easily arise from fatigue or unexpectation. Compassionate dialogues prevents emotional distance and build trust. And how practice compassionate conversation for parents: listen before reacting. When you're dealing with the patient, and listen before reacting, silence can be healed. Then replace judgment. You should with then validate emotions, express appreciation for families, offer support, not advice unless asked. Avoid criticism of parenting style. Encourage instead respect, rest, privacy, and new family rhythm. And the healing powers, compassionate dialogues should be. What does it will do? It will lower the stress and lower the things, and it will give more chances. Postpartum depression doesn't affect just a person. Father may feel helpless or distant. Grandparents may also face a problem. Children can see tension, sadness at the home. When one person suffers, the whole emotional system feel it. The new model of care looks at family healing, not just individual treatment. Let's ask yourself, प्लीज आस्क वन क्वेश्चन कि दैट आप में से कितने लोग हैं जो काउंसलिंग करते हैं उसकी फैमिली को बुलाते हैं और यू हैव द कंप्लीट डेटा अबाउट द problem about the family issues, about the family integration, and mostly the patient comes alone or come with the mother, hardly come with the husband, but it is a triangle. It is a triangle between the family, between the parents, between the father, between patient itself. And when one person suffers, it is very rightly the new model of care look family healing, not just individual. And family healing, you should see the sociology. You should be three: the biology, psychology, and sociology. These are the three strongest players. These are the three strongest thing which you should be, remain in touch. Because that exactly what the psychology team effort. Then psychoeducation teaches family open communication and it shared the helping the therapy couples and strengthened understanding teamwork support is not only medication, it's love and empathy. You should give love, you should give time, and you should give empathy. And then this is a very important slide. What I believe now, there are part of prevention, education, and family planning. The past psychologists joined care in the crisis, working in the maternity clinic, schools, and the community programs. Psychology scope is expanding, early screening, counseling, research, awareness, and all. Then neuroscience is mapping, the digital therapies are coming, virtual reality, relaxation, or the and then community psychology, training local women as per support. The future of then what I believe that the cultural, cross-cultural, uh, the cross-cultural research shows higher stigma but stronger family bond. Pakistan and India 2024 community counseling reduces depression by 40%. WHO project teaching nurses and midwives basic psychological skill. The new goals, so mothers should face depression in silence. Why the nurses and why the doctors should be given only what I believe it's not weakness, it's a human response to huge changes. Healing comes from connections, understanding, and care. When the mother's mind heals, the whole family heals. Psychology brings new light, helps us not only the illness, but the person behind it. Let's remember a supported mother builds a stronger generation. Science explains it, compassion completed. Question for reflection. How can we make postpartum mental health more visible in our communities? What role do you see for young psychologists in this field? How can tradition and innovation work together? What I wish you all should answer me these questions in my WhatsApp and all. And what I believe, what exactly the meanings of the new thoughts, news that in the world, the psychology, when we talk about the depression, it is related also, they are having full access to the gynecology department, they are having full access to the women health department, they are having full access to the maternal and child health section department. So what I wish, what is the message of the day? What I wish that all the obstetrics and gynecology department in Pakistan must open the doors for the psychology student, and they should give them updated knowledge. They should give them updated information. They should give them updated each and everything. If we the clinician and the psychologist, if we will come together, तो we can make a better Pakistan, a better women health. मुझे फख्र है आप सब पे, मुझे नाज है आप सब पे, और मैं समझता हूँ कि आपके अंदर भी इल्म का जज्बा उतना ही मौजूद है जितना मुझ में है. Let's Dr. Elias and you all, we come together. We, the clinician, and you, the from the psychology, must be on equal, on the equal right, equal pathways, equal direction, and equal everything. Thank you so much, and I'm so grateful to each and every person. I'm grateful to Dr. Najma Malik, Professor Dr. Najma Malik, all the students, the Honorable VC. And I believe the new thought is come together. The new philosophy is join together. New philosophy is work together with the clinician, and psychologist should be the pure clinician, and pure clinician should be having a heartbeat like a psychologist. If me and you, you and we come together to work for a better patient care, तो आने वाला वक्त एक बहुत बड़ी चेंज होगा. खुदा हम सब का हामी और नासिर हो. प्लीज गिव मी योर फीडबैक. जज़ाकल्लाह.